Well, good morning, everybody. How are you doing? I am so happy to see you all here today. Thank you for finding us. Thank you for registering, and thank you for being here. And so I'm going to ask everyone, and I know lots of people were anxious about how do I get here? This is a new place. How many people are here for the first time? Look at that. So yay. I'll introduce myself. My name is Eileen Bird. I'm the executive director of 2Life. I've worked for 2Life since 2011. And in 2011, I think my very second day of work was the conference day. Think about that, like second day of work, right? And so other people had organized it. And I was just so taken by what I didn't know. Do you feel that way sometimes? And so I appreciate that, that today is an opportunity for us to kind of close out to the best degree that we can some of the other things that are happening and take a moment to appreciate all the wonderful knowledge and the people that we've assembled. They've worked really hard to really put material together that's going to make some sense. And at times, and I'm going to warn you about this, you're going to say, this is over my head. Have you been at something and it's over your head? And so be patient with yourself. Can I say that again? Let's be patient with ourselves and take what we can, because we're all going to come at this day from a different perspective, myself included. So with that said, I'd like to introduce Mara Ginsburg, and she wants to say a few words. We're working from the microphone because we've got a lot of things all squared away, but the microphones are locked up. So there you have it. So we're working from this microphone now, and Mara, welcome.
It's always good to follow Eileen because she's of similar diminutive stature, although I am standing on my tippy toes, just for the record.
Bring a stool, right?
So I'm gonna like feedback. I'm just gonna yell. So I'm the founder of 2Life, and it's our 25th year, which is astounding to me because a lot has happened in 25 years. My kids have grown up, and I'm still here to haunt them from this side of the grave, which I think is generally a good thing from their perspective. This is probably our first event was 1998 in October, and it was an education program. So the education programs are the core of what 2Life does, because the whole point is to help people become more familiar with what's going on, not just with their bodies, but in science and in our wider community for healthcare, so that we know how to best take care of ourselves and our loved ones and our friends. So thank you for being here, and take away from this everything that you can, and we will record it. And if there's something you want to like rewatch later, you'll be able to do that too. And we really appreciate and are happy that you're here with us today. So thank you.
Our technical expertise is we're going to turn the volume up a little bit. Okay. Oh, there. Okay.
Hey, friends, is that better? No? Yes?
No. No.
Any better? That's better, right?
Okay. Okay.
Too much? How's that? Feedback?
All right. Well,
I think
Okay.
that works right there.
there we go. And I have to bring the microphone down. So a couple housekeeping things. One is that all of our presentations today will be in this room, with the exception of the 11 o'clock time frame, when we're offering an opportunity for, I'm going to bring this. Nope. Hello? Okay. So I'm just coming down just a little tiny bit. Yeah. And so in the 11 o'clock hour, the presentation on caregiving, you'll have an option to choose one or the other. There's no signups. We have plenty of space and seating in both of those areas. Will be in the room right behind the registration desk. There's restrooms down the side. Our lunch, and this is really exciting, is going to be in the building next door. It is literally like a 1-minute walk and half of it will be inside. And so that is the Cancer Research Center. And Nicole's has prepared a wonderful lunch for us. And the way we're going to do lunch is that half of our group will start through lunch immediately following the 11 o'clock presentation, which ends at noon. And the other half has an opportunity to do tours of the labs. And so a couple of the labs, actually many of the labs, are doing research in the area and field of breast cancer. So you'll get another feel for what's going on in our community to further advance treatment in the future. So we're pretty excited about that. Doug Conklin, who's the director of that center, is going to be leading those tours. All right, so a couple other things. I want to say thank you to our sponsors. And so our presenting sponsor today is the Albany Med program. They have tables in the back, and we are just delighted to have their support, and on a very big day. But other sponsors with us today include Akera, Cox Marketing, NYOH, Fenimore Asset Management, Godfrey Financial, and our media sponsor, the Women at Work program. And so I think that is the last thing. If you don't mind silencing your cell phones, don't turn them off, but silence them as we go on. And now I want to bring up Barbara McDowell, who is a member of our board of directors, and she's going to get our program started.
Thank you, Eileen. Good morning and welcome. I again would like to take the opportunity to thank you all for joining us on what will be an information-packed day, so get your pens ready. I have the privilege of being asked to introduce the first two speakers of the day from Albany Medical Center to kick off our 13th Women's Health Conference, Choosing Wisely. Excuse me. Two words that can have such a significant impact on your cancer journey. In a time where medical treatments have advanced, often the treatment options and choices can be overwhelming. Our first two presenters will detail the national initiative to assist in recommendations for testing and treatments to begin and maintain a healthy dialogue with your physician and your care team. Dr. Lynn Choi, personal friend of mine, a well-respected breast and general surgeon, is currently the director of the Breast Center at Albany Medical Center. Dr. Choi received her medical training at the University of Mass Medical Center and Albany Medical Center, and went on to receive her residency training and advanced breast fellowship training at Albany Med prior to joining the full-time staff. Dr. Edward Farhangi is currently the chairman of the Department of Radiation Oncology at Albany Medical Center, with over 20 years experience as a radiation oncologist. A graduate of the University of Chicago, he received his medical degree from Rush Medical College. It is my honor to introduce to you Drs. Choi and Dr. Farhangi.
I'm just getting your presentation out this one.
Hello?
Oh, you do have your microphone. Oh, you do have a microphone.
Hello? Can you hear me? No. Hello? I should just put it up here. Okay. Thank you so much for coming here. Thank you to Life for bringing this wonderful conference together. My talk will be titled Choosing Wisely, De-escalation of breast surgical care. It's really about empowering yourselves as the patient to ask questions when you're with any sort of physician or nurse, PA. Okay, so choosing wisely is a pretty well-known phrase in the medical field. It was an initiative of the American Board of Internal Medicine Foundation. You can look this up, Choosing Wisely, ABIM. And it basically was designed to promote conversations between doctors and their patients. Do you need the treatment that they're recommended? Do you need that extra test? It's a campaign basically to empower patients to really understand their health and what treatments are being recommended. So it began in 2012 with national specialty societies, and now there are more than 80 specialty societies. What does this mean? So for a breast surgeon, the society we follow is the American Society of Breast Surgeons. If you go to colorectal, they have their own society. So every field of medicine has their own society, and they are the ones that put out guidelines that we should adhere to give you the best care. So for anyone in the audience, if you have any medical issue or health concern, these are 5 questions you should always have in the back of your head. Do I really need this test or procedure? What are the risks? Are there simpler, safer options? What happens if I don't do anything? How much does it cost? Oftentimes I find patients who come in and we as doctors give them, you need this, this. And then they say, okay, you book surgery. They go home and they have a slew of questions. Think about this for any sort of doctor's appointment you have. So again, the society that breast surgeons should be following is the American Society of Breast Surgeons. They are one of the 80 societies that follows the ABIM, and they give their recommendations. They developed a list that targets 5 evidence-based recommendations related to the care of benign breast disease and a list of focused treatments on breast cancer. I'm sure everyone's like, oh, I want to know all the things about benign and breast cancer. Look them up. I'm going to go over one of the things, and this is what my talk will follow. So out of the 5 evidence-based recommendations for breast cancer treatment, the American Society of Breast Surgeons say, don't routinely excise all the lymph nodes under the armpit in patients having a lumpectomy for breast cancer. I'm sure there's people in this audience are like, wait, I got them out, and that's fine, because at differing times, there were different recommendations. But the way breast cancer surgery is going is it really is about de-escalation of care. Doing less can actually be more. I'll just let you know the 2 things I learned at becoming a surgeon. Don't trust anyone. And the second thing is, don't have surgery if you don't need it. Okay, I'm going to talk a little about axillary or armpit surgery. So if you are a patient with a newly diagnosed invasive breast cancer and you're a candidate for a lumpectomy, you benefit from having an axillary surgery. We call it sentinel lymph node surgery. So there's a picture of the axilla and the breast. So the axilla is what we term the armpit. If you have a breast cancer, the first place breast cancer drains to is to the lymph nodes in the armpit, to the axilla. I don't know if I can point, but if you see where the nipple is, there's all these green little tributaries. Those are lymphatics. When I talk to my patients, I basically say the lymphatics are like roadways, all these multiple different roadways to get to all the different lymph nodes in the armpit. So a sentinel lymph node biopsy is a procedure to basically remove the first lymph nodes that would drain the cancer. I tell patients there's about 20 to 30 lymph nodes in the armpit. You only want to take the lymph nodes that is in the pathway of the cancer if you didn't take care of it. So the first lymph nodes that drain the cancer are called sentinel lymph nodes. In the past, before 2011, I would even say 2013, 14, the majority of patients had axillary dissections. So let me talk about that. So here's another schematic of the axilla, the armpit. I'm going to just point to this because the pointer doesn't work. But everyone has a chest wall muscle. So you basically have a pectoralis muscle. Then you have this thing called the pectoralis minor. Lymph nodes that are lateral to the pectoralis minor are level 1. This is more surgical terminology. Then you have level 2 right behind it, and level 3 is medial to it. So when we offer an axillary dissection, it is removal of level 1 and level 2 lymph nodes. Axillary dissection is removal of all the lymph nodes at level 1 and level 2. There's a higher morbidity with this procedure. There's an up to 30% risk of lymphedema. Lymphedema is permanent arm swelling. It can be debilitating. Some patients can have a little bit of swelling. Some patients can have their arm doubled in size. What if that's your dominant hand? What if you're a painter? What if you're a writer? So there's a lot of morbidity with this procedure. And the other thing that I tell the patients, if this treatment is being offered, is there's two major nerves that run right along your chest wall, the long thoracic and thoracodorsal nerve. If one or both of these nerves are injured, you will have something called a wing scapula. You can't shrug your shoulder. So there's two types of axillary surgeries that we offer. A sentinel lymph node biopsy, just take a couple of the lymph nodes that would drain the cancer. I tell patients is usually 1 to 4 lymph nodes. Then you have the axillary dissection. So what changed that now? Why is the majority of axillary surgeries offered sentinel lymph nodes and not an axillary dissection? There's this pivotal trial. This is probably the most talked about paper in all of breast cancer surgery. This was done by Armando Giuliano. He's wonderful guy that I've met at conferences. He's the guy who actually proposed the whole idea of a sentinel lymph node biopsy. So what he did is he enrolled and randomized almost 900 patients with breast cancer, less than 2 centimeters, a clinically negative axilla, meaning when anyone's examining your armpits, they don't feel anything abnormal. And what he found was that when these women with a sentinel lymph node biopsy had 1 or 2 positive lymph nodes, you did not need an axillary dissection. So before this paper came out, anyone with 1 or 2 axillary sentinel lymph nodes would get an axillary dissection. This pivotal paper basically showed that there's no overall survival difference between patients who have sentinel lymph node with the 1 or 2 positive lymph nodes or patients with the axillary dissection who had 1 or 2 positive sentinel lymph nodes. You have to know that this is a small, fairly favorable tumor, and these women had lumpectomies and had radiation. Okay, now we're moving to 2023. So we already talked about de-escalation of care and trying to avoid axillary dissections, which is used by the majority of breast surgeons. Everyone is going to try to offer you a sentinel lymph node biopsy if you fit the criteria. This is a pretty thought-provoking paper that just came out in September in 2023 in JAMA Oncology. It's called the SOUND trial. So it's basically comparing women with sentinel lymph node biopsies and women who don't get any axillary surgery in patients with small breast cancers. They're saying favorable, and negative ultrasound in the armpit. So clinically negative armpit axilla, and you do an ultrasound and the lymph nodes don't look abnormal. They randomize these patients. I'll tell you what they found right now before I go into everything, but they're saying there's really no difference for the 5-year data that they found. I'm sure there's a lot of people in this room saying, oh my gosh, I got a sentinel lymph node biopsy. If I was offered it now, I would still definitely do it. I'm not telling you to change people aren't going to change their practice right now. They're going to wait for more data, but this is pretty thought-provoking. Okay, so I'm just going to review it again. So for me, when I have patients who come in for a consultation with breast cancer, and they've usually come in with the full mammogram, and they've also sometimes had an ultrasound, most of the radiologists, oftentimes when they do an ultrasound, they will also ultrasound the armpit. It's pretty standard of care. And they look if the armpit looks fine or not. If you see in the top picture, there's a benign looking lymph node. You kind of see a rim. You want to see the rim. That's a cortex. It has to be a certain size. And then in the center is the hilum. The hilum is where all the blood vessels are. If you go to the picture below, see how it's just one big circle and you can't see the cortex or the hilum? That is an abnormal lymph node. So the patients who are enrolled in these trials, small breast cancers less than 2 centimeters, and had a negative ultrasound. And then there's this whole caveat that whatever you end up finding won't really affect the post-op treatment. So again, this study was designed to see that if you can omit a sentinel lymph node biopsy. While again, I just want to stress to you, while this trial is unlikely to change practice immediately, it is a thought-provoking study that will likely generate multidisciplinary discussion. It's a phase 3 randomized controlled trial. It was done in Europe. There are 18 European hospitals, 2012 to 2017, patients with tumors less than 2 centimeters, clinically no negative axilla armpit who are planning for a lumpectomy and radiation, who had the ultrasound. So you have to tick all those boxes to be part of this. And basically, half of the women ended up having the lumpectomy, and half of the patients ended up having a sentinel lymph node biopsy. Median age is 60, tumor size 1.1. Almost 90% of these women had a hormone-positive breast cancer. If you have a breast cancer, the most favorable breast cancers are hormone positive. So we're talking favorable tumors. In the group of women who had the lumpectomy and sentinel lymph node biopsy, almost 14% had positive lymph nodes. And I broke it down on the last sentence, how many had micromets, how many had macro, how many had more. But 14% of these women ended up having positive nodes. If you want to further compare these two groups of patients, patients with the sentinel lymph node biopsy, 20% ended up having chemo, 17.5% of patients without the axillary surgery also received chemo. Overwhelming majority of patients in both arms, 98% on both sides, received radiation. So if you want to see if you've fit criteria, you have to have radiation for this. And then it's broken up what kind of radiation you had. Here's a picture, sentinel lymph node surgery, patients who had the lumpectomy and sentinel lymph node, compared with a group of patients who did not have axillary surgery. And you can really see that everything is fairly comparable in both groups. I didn't put the table in here, but the table basically compares both groups, like similar tumor profile and many more factors. They're very comparable. So if the sentinel lymph node surgery group of patients showed almost a 14% rate of positive lymph nodes, then you would probably assume that the group of patients without the axillary surgery also had a similar positivity rate of lymph nodes. Conclusions. There's 4 conclusions I'm going to go over. Patients with small breast cancers with lymph nodes that look normal in the armpit by ultrasound can be spared axillary surgery. This study basically shows that if you have axillary lymph node surgery, sentinel lymph node surgery, it doesn't provide a therapeutic benefit, because in the table I showed you before, both arms had very similar disease-free survival and local regional recurrence. And here is very surprising, not surprising, but it was a very significant fact. So in the arm of patients who did not have sentinel lymph node biopsy, the cumulative incidence of lymph node recurrence in the axilla was 0.4% at 5 years, despite the group of patients who had sentinel lymph nodes had a 13.7% rate of positive lymph nodes. I hope that makes sense. I think the importance of this is, well, my colleague, Dr. Farhangi, will go next, is the importance of radiation. So I don't think breast surgeons will be implementing this as standard of care in the next couple of years. But I think when we have 10-year further data, and if these patients, I'll explain some of the caveats, that maybe this might be the standard in the next 5 to 10 years. I think it is very important to know this because we have a wide range of patients, and sometimes you will have that patient come in with multiple comorbidities, can't get out of the wheelchair, needs help, where, you're a little afraid to offer them the standard of care. But now I think papers like this will give the physicians more comfort in saying, I'm not going to offer you a sentinel lymph node biopsy. This is the data. I feel comfortable with this. So I said there are 80 societies that were part of the ABIM. One of the other societies is the Society of Surgical Oncologists, SSO, and one of their Choosing Wisely guidelines, I didn't put it here, but they basically said hormone positive, favorable breast cancers in women over 70, you can eliminate having a sentinel lymph node biopsy. The difference between this is they're not saying women over 70. This is generalized women who fit the different criteria. Again, we get a lot of patients who question, why do I need this? Why do I need radiation? I'm definitely not going to have radiation. You have to have radiation to be part of this trial. So some of the caveats, when you have an invasive breast cancer, you get your receptors and they're graded, grade 1, grade 2, grade 3. Grade 3 is a more aggressive flavor of the cancer. And I think what would be great for this paper is they said 18% had grade 3 disease. Maybe do a paper with grade 3, because I would feel more comfortable really thinking of omitting a sentinel lymph node biopsy more for a grade 1 tumor than a grade 3. So this is a multidisciplinary discussion. There's more trials going on. The message of my talk is you are the patient. You're only here if you have good health. So if you go into a room with your doctor and you just listen and nothing makes sense and you don't question them, you really should. Doctor, we're all the same people. Say, are you sure? If this was your mom, would you do this? Why do I need this? Do I need this test? Question people. It's not whether you're questioning their judgment, you're just taking more power and control for your health. These are my references. Again, I want to thank Two Life for this wonderful conference. If you need to contact me, there's my info. Thank you so much. And then this paper required radiation oncology. So next will be my esteemed radiation oncologist, who we, on a weekly constant basis, we're always having multidisciplinary discussions about patients. And I will say Dr. Farhangi always questions everything, not because he questions you, but he wants to say, is this right for the patient? Thank you.
Thanks.
That should work, but I don't know if it's. We're just doing a technology swap out here.
All right, can you folks hear me with this? Yeah, okay. All right, let's see here. So thanks for inviting me, as Two Life folks, and I'm glad all of you turned out today. Feel free to interrupt and ask questions as we go through here. I'm starting off using the choosing wisely framework to talk about how we think in radiation oncology and make decisions. So as Lynn said, the Choosing Wisely campaign was initiated by American Board of Internal Medicine and speak up.
Do you have the mic?
I believe I do. Let's see. Is this better?
Oh, Dr. Choi said she had to put it right at her mouth. You know what? This is podium mic is on mute. Let's take it off mute. Try that now.
Is this one? Which one is working?
Sorry about that. I'm not sure.
Is this a podium mic? You guys hearing that? Okay. So me
Forgive me for a minute.
so in terms of the Choosing Wisely campaign, our professional society in radiation oncology is the American Society for Therapeutic Radiology and Oncology, ASTRO. There were two recommendations that they made in regard to breast cancer. One is consider shorter courses of treatment for women over the age of 50 with early stage breast cancer, and then do not routinely use intensely modulated radiation therapy to deliver whole breast radiation therapy. The second point is using advanced technology, which is labor intensive and costly, and essentially does not confer any clinical benefit in most cases. Things are pretty tightly controlled by the payers, and they're not paying for IMRT. So in clinical practice, that has not been so much of an issue. It is not routinely used, and that's appropriately so. The one I really want to focus on is using shorter courses of treatment. There's a long history of the use of radiation therapy in breast cancer. As I'm sure you guys are aware, historically, our treatment approach was extensive surgery. It was the radical mastectomy. And really, over the past 7 decades, we have been de-escalating therapy. We found that by using less aggressive surgical techniques and adding radiation therapy, we can confer similar survival outcomes with a less aggressive surgery, less disability, and less permanent side effects. So those studies were started in the 60s and 70s and typically used a 6.5-week course of radiation therapy. The idea is that by breaking the treatment up into a small amount every day over a long period of time, the normal tissues are able to recover the injury of radiation, whereas the tumor tissues do not do such a good job of repair. And by doing that, we're able to eradicate any residual cancer cells that may be in the breast or in the lymph nodes, and at the same time minimizing side effects on the normal tissues. So we use a unit of measure called centigrade. So 6,000 centigrade was the standard treatment over 6 weeks. And particularly in Europe, they started studying using shorter courses of therapy and looking at the outcomes. In nationalized health systems, there's typically more constraint on resources. A lot of the European countries have a limited capacity for radiotherapy patients, even more so an issue in the developing world. So they're very motivated to seek ways to reduce the treatment burden on the patient, as well as improve capacity with scarce resources. The treatment machines for radiation oncology are extremely expensive. We can only treat one patient at a time. And in many parts of the world, that's a rate limiting step. Patients can wait weeks or even months to get onto treatment. So I want to introduce this concept of the therapeutic index because I think it's helpful in terms of how we think about making decisions in cancer care. This is an outgrowth of looking at the effects of drug therapy, but the same thing applies to radiation therapy and other modalities. On the left-hand side of the graph is what we call the therapeutic effect. The higher the dose of the intervention, the greater the chance of success. So in our case, the therapeutic effect would be local control, the prevention of recurrence of the cancer within the breast. So if you use a very small amount of radiation, it's unlikely to be effective. If you use a very high amount of radiation, you're very unlikely to have recurrence. The problem is the toxic effects of your intervention also correlate with dose in most cases. So the second sigmoidal graph to the right is the toxic effect of your intervention. So we're trying to exploit that differences in those curves and choose an intervention that has a low chance of toxicity and still a high chance of efficacy. As you can see, if those two graphs are close together, it's hard to really exploit that. Whereas if the two graphs are separated by some distance, you can choose a low dose, a dose that will be effective and still have low toxicity. So over here, low chance of side effects and moderate chance of success. A very high dose, we have increasing toxicity, although the effectiveness is increased. If we can separate these two curves, then we can improve the therapeutic index. So one of the toxic effects of our therapy is just the treatment burden on patients. The amount of time it takes to attend to therapy takes them away from their work, their families, their children. And that's not to be underestimated. So I think in this context, we can look at the toxic effects as the treatment burden of the therapy, 6 weeks of therapy versus 4 weeks of therapy. And so by reducing the length of the treatment time, we're essentially moving this curve to the right, reducing the burden on the patient and still having efficacy. When we treat a patient with radiation therapy, they go through a planning session so we can customize the treatment to each individual patient. We acquire a CAT scan in the treatment position, and that's used to calculate the radiation dose. This is what we call an axial images. If we were standing at the feet looking up, the black here is the lungs. This is the breast tissue, and this shows you the dose distribution that we develop from the treatment plan. Essentially, there are two beams, one coming laterally and one coming medially to treat the breast, and we want to give a uniform dose of radiation. These colored lines represent different doses. It's kind of like a topographic map. And this just shows you a representation of the patient. She's laying on her back with her arm up, and these lines here represent the border of our treatment field. So this planning process has improved dramatically. It's another aspect of improving the therapeutic index. As the computational power has improved, we're able to use the technology to better refine our treatment plans. One of the factors that drive side effects is the uneven dose of radiation. Essentially, in the past, we had to provide a uniform dose of radiation across the field. But because of the dose distribution in areas where, like the bottom part of the breast, where there's skin touching skin, we would see a lot of side effects, a lot of skin toxicity. We've improved the treatment planning process to reduce that. We both, on the planning side, where we can improve the dose distribution, reduce the hotspots, also in the technical factors of how we set up the patient and mobilize them. We avoid skin folds and things like that. So that allows us to use these shorter courses of radiation. We're giving more dose per fraction over a shorter period of time, which potentially could result in higher side effects. But because of the improvement in the planning techniques and treatment delivery techniques, we don't actually have any increase in toxicity. We measure a lot of parameters about the treatment plan to evaluate its effectiveness and safety. So for left-sided breast cancers, we're always concerned about the dose to the heart. For both sides, we're concerned about the dose to the lungs. And we can quantify the dose distribution now. After a few decades of experience and getting more quantitative data, we're able to predict whether this treatment plan can be delivered safely or whether there's risk of injury. If we find that there's risk of injury, then we go back to the drawing board and further work on the plan so that the parameters come within the safe ranges. So this is one of those hypofractionation trials that's comparing the conventional treatment over 6 weeks to a shorter course of treatment over 13 to 15 fractions. the top graph shows you the local control, meaning what is the chance of having cancer come back within the breast itself as opposed to someplace else in the body. Essentially, the surgery and radiation is a local therapy. We can only have effects there. It's the systemic therapy like endocrine therapy and chemotherapy that reduces the risk of cancer coming back elsewhere. So the local control is the measure of the effectiveness of the treatment plan from the surgical and radiation oncology standpoint. And you see that on the top, those two graphs are superimposed. Whether it's the longer course or the shorter course of radiation therapy, there's an equal chance of recurrence, which is relatively low. On the bottom graph is overall survival. That's our ultimate endpoint in oncology. And again, the two graphs are superimposed. There was no significant difference between the two treatment arms. Not shown here also is looking at the side effects of treatment, and those two were essentially identical, perhaps slightly less side effects in the shorter course group. So this graph shows you the adoption of hypofractionated radiation therapy in the United States. Doctors are sometimes slow to change. We want to see multiple sources of evidence. For oncology care, we want to see long-term results. We need to see 5-year data, 10-year data to be confident that those two treatments are equivalent because of the long natural history of breast cancer. So there is some barriers to adoption. There is that reticence to implement new things until we have multiple lines of evidence. There's some financial implications for hypofractionation. In the United States, our compensation system is set up to essentially pay more money for more treatments rather than paying a standard amount for a course of treatment. So that kind of incentivizes people to give longer courses of treatment. But nevertheless, the good news is that we can see dating back to 2004 to 2016, there was a fairly rapid adoption of hypofractionated radiation, which is the red line at the bottom that's going up. And you can see the conventional fractionation, whole breast radiation is declining, whereas the overall radiotherapy use is stable over that time frame. This is another trial that's also done in Europe. Again, they're really leading the way on hypofractionation for breast cancer. And this trial is looking at treating women over a 5-day course of therapy. So going from 6 to 6.5 weeks down to 5 days. And again, these different graphs show the moderately hypofractionated, the 3-week course of radiation compared to 2 1-week courses of radiation, and finds similar low rates of local recurrence. So this is something that's widely adopted in the UK. It's something that's not widely practiced in the United States. We've just recently started offering this to patients over the age of 80 who are interested in pursuing radiation therapy treatment. Again, this trial has less follow-up. We have follow-up to 5 years and not beyond at this point. So I'm a little bit leery to adopt it for younger women who have a long expected survival. Another implication of hypofractionation is on the population level by reducing the cost of therapy. Again, the machines are expensive. They're highly qualified technical staff that operate the machines. And so if we can reduce the number of fractions delivered per patient, there's less burden there. We can treat more patients and the overall cost of the health care system is reduced. So these graphs on the left are looking at the reduction in cost per course of therapy for hypofractionated breast cancer treatment versus conventional for both breast as well as for prostate cancer. We have similar progress in prostate cancer treatment where the treatment courses have diminished from 9 weeks down to 4 weeks, and in some cases also 5 fraction treatments. What I didn't show here is also again, the reduction in machine times that we can achieve with shorter courses of therapy and allowing increased capacity. It's not so much of an issue in the United States where we have excess capacity, but in developing countries where there's long wait times to start treatment, I think this will have a a dramatic impact and allow us to treat more patients. So in conclusion, I think we have to understand it's somewhat of a moving target. Our treatment recommendations evolve as data becomes available. Again, we're very conservative in that we want to see multiple studies published on the same topic, all confirming, coming to the same conclusions. For oncology care, we want to see long-term follow-up data due to the long natural history. Particularly with radiation therapy, we want to have long follow-up data because the toxicity of our treatments can actually increase years and decades after therapy. So patients may appear to be doing fine right after therapy, but they may develop toxicities decades later. So we always want to be a little bit cautious. We want to be very confident. The way radiation oncologists think about things, we're looking at the therapeutic index. We want to maximize that therapeutic index by reducing the treatment burden, reducing the toxicity of our therapy, or increasing the effectiveness. I think in the case of breast cancer oncology care, we have some very effective therapies, and now we're looking at really kind of de-escalating, as Dr. Choi was saying, backing off on our therapy without compromising the effectiveness. So when I started practice, we routinely would see a good portion of our patients with permanent lymphedema or swelling of the arm, which can be a very challenging management issue and have really negative impacts on their quality of life. Nowadays, it's really quite rare for me to see patients with that complication, thankfully. So I think we're moving forward. We're improving the effectiveness of therapy and at the same time reducing the toxicity and the treatment burden. Hypofractionation is just one example of where we're going in radiation oncology to reduce that treatment burden and maintaining the effectiveness of our therapies. So thank you for inviting us. I think Dr. Choi and I have a few minutes. We can take questions from anyone.
So you definitely have time for questions,
Yeah.
and I would imagine that both of you will have some opportunity. So it's Eileen again. Hi, we have a microphone set up in the back. And so if anybody has a question, if you want to proceed to the microphone or raise your hand, I think we're a small enough group that if you have a projecting voice, which I don't necessarily have, but many of you do, ask away.
Projecting voice.
Vanessa, good morning.
Good morning. I have a twofold question. I really like the idea of choosing wisely. Less is more. But when you're caught in that situation where you hear that word and that word throws you into this oblivion of hopelessness, you come to a physician, surgeon or otherwise, and you're deferring to their knowledge, deferring to their professionalism. If you're teaching us this is the first part of the question. Are you teaching your professionals this concept? Because if I come to you and I say, hey, wait a minute, if this were your mom, if this were your sister, would you do this? And I'm about to cry really right now, but I'm bawling or whatever. There's a fear inside of me to say that they're gonna say, well, you know, I don't want to see this person because they're questioning me. I want to be able to be in a safe space to ask that question. So, I mean, the better question, I guess, is, are you teaching your professionals the same thing?
Yeah, that's a good question. Yeah, I think there's been wide interest in adoption. As we said, the Choosing Wisely campaign has support from over 80 professional societies, so individual medical specialties. So there is a lot of buy-in there. I think it is something that is being taught in medical school and residencies. It's being actively discussed. As Dr. Choi said, we have a tumor board, a weekly conference with physicians, pathologists, radiologists, in which we discuss management. So yeah, I think it is something that we are trying to implement. Certainly when you're going into the physician's office, they're there as an advisor to you. That's their job. You're paying them to advise you on what's best for you. So I think you should really have no qualms or hesitancy in questioning and asking questions. You know, a large part of my time is really just spent educating patients, telling them what their options are. And I think even going beyond that, giving them context to allow them to interpret the data and make good decisions. I can't just say, here's 3 options, choose, because you don't have the background and training. So we need to provide that context and background so you can make those educated decisions. Now, as a physician, I find that each patient is different. They have different goals, different issues that concern them. So it's very hard. I can't give patients a blanket answer. You have to understand not only the science and the medicine as to what's effective and what's an option, but then you have to put that in the context of the patient, what their goals and desires are. So you can come to different treatment decisions based on how the patient is approaching things and what their primary goals are. So again, I would encourage everyone in the audience, have no qualms about asking questions and making sure you understand what's going on. That's the whole point of the consultation, really. So the patient understands and we can develop a joint plan.
I totally agree with him. If you feel like your physician is feeling uncomfortable that you're asking these questions, go get a second opinion. You should always feel comfortable that they're there, not whether they'll be able to book the surgery. It's about them making you feel comfortable going forward with your decision.
Dr. Choi, can you repeat those 5 questions or maybe show the slide?
Oh my, I have horrible memory, but wow, I can repeat them. Yeah, okay. Here's the 5. Do I really need this test or procedure? What are the risks? Oh, I have them here.
Okay.
Are there simpler? Oh yeah, if you can
Yeah.
put it up.
Trying to.
Oh, then everyone can take a screenshot. What happens if I don't do anything? How much does it cost? This actually all came out based on prostate cancer because there are a lot of questions about why is this being ordered? Is this over treatment? And a lot of patients just come in and they just, you know, oh, I need this, I need this, I need this. Okay, okay, okay. So you should really be proactive with your health.
Add something on that. All I'm gonna say is that I actually downloaded the PDF of this. How about I send it out to everybody? Would that be helpful? Okay, so don't worry about writing them all down. You will get the PDF.
I can get the PDF for the benign breast lesions and for the breast cancer, and then maybe Eileen, you can send that out too.
If you don't have your email, write it down.
Dr. Farhangi, I was wondering about the radiation boost, which my oncologist left it up to me whether I wanted it or not,
Yeah.
and I really didn't know what to do. So this was last year, but I just wanted to know more about it.
Yeah, the boost. So the typical course of treatment for breast conservation is initially treating the entire breast, which means from the middle of the breastbone, from the collarbone down to the skin fold bone of the breast and to the mid portion of the axilla. A lot of times patients are surprised that there's actually breast tissue that does go all the way up into the axilla. So that's whole breast radiation therapy. And that the conventional course is 5 weeks. Now we're doing that in 3.5 weeks. The boost is a few additional treatments that's focused just on the area where the cancer was within the breast. So we're not treating the whole breast, we're just treating what we call the tumor bed with a small margin. So that's getting a higher dose of radiation. And the concept is that the more tumor cell burden, the higher dose of radiation we need to use to get rid of it. So there may be only a few cells far away from the lumpectomy site, but there may be more cancer cells at the lumpectomy cavity. So by giving a higher dose of radiation, we can reduce the risk of recurrence. We're getting towards the top of that sigmoidal dose response curve. So it's hard to measure the value of the boost. It makes only a very small difference. And it probably only makes a difference in women who have more aggressive cancers. So that means younger women versus older women, higher grade tumors and things like that. So essentially, if you have an older woman postmenopausal, favorable histology, ER/PR positive, their risk of recurrence at the lumpectomy cavity after standard treatment is low. So we can't really prove or measure the value of the boost. So we omit it sometimes. I think that's the challenge, is when we say, do you want this or not? The patient doesn't really have enough context to interpret that and make a decision. The radiation oncologists have a hard time making that decision. So we can't expect the patient to make that. So the boost is something that's kind of optional in the more favorable breast cancers. That tends to be lower grade, older patients, ER positive. The flip side of that is the toxicity of doing the treatment. It's 3-4 additional visits, but there's not a lot of additional toxicity. So because of that, you're weighing the risks and benefits. Because the risk is low, it's fairly commonly used.
In the SOUND trial, were women stratified based on age or other comorbidities? And I apologize if you mentioned that.
Oh, so I didn't mention it. You were listening quite well. They wasn't really stratified. They were all put together, but there are different characteristics about everyone. I don't think comorbidities were in there, and it wasn't stratified by age, but the median age was 60. So I do feel like this trial, if we start implementing it in our practice, I would have a hard time doing it on younger patients or robust postmenopausal patients.
I have a question about the standard of care from the time you're diagnosed and initially see your doctor until you go to surgery to have the tumor removed. And also, I have lymphedema. Did that come from the radiation? I had 2 sentinel nodes removed. I just was kind of curious, the oncologist doesn't really give me a straight answer on where this came from.
When I offer the sentinel lymph node biopsy, I say there's a 4% chance of lymphedema. So that could absolutely be done from surgery and radiation, likely a combo of both. The standard of care that I follow, again, the American Society of Breast Surgeon guidelines, and also the National Cancer Comprehensive Network, NCCN. If you look that up, that's the Bible for all cancer guidelines. So based on NCCN guidelines and American Society of Breast Surgeon guidelines, we recommend your surgery be done within 30 to 60 days of biopsy date. That's the recommendation. If you have a more aggressive cancer where surgery is recommended upfront, I'm going to try to get you in sooner. More favorable tumors like hormone positive, if you have travel plans, doesn't matter if I take you yesterday or if I take you 59 days later. So that's the guidelines.
Dr. Farhangi, good morning. Could you elaborate a little bit in the United States? How often is the 5 treatments in 1 week being adopted in one situation versus 3 to 5 weeks, and what the current outcomes are with the data?
I don't know the answer to that. I haven't seen anything published on the adoption of the UK Fast Forward trial. So I don't think the adoption is very widespread. To my knowledge, it's mainly in academic medical centers where it's being offered at this point. What we didn't go into today is something called accelerated partial breast irradiation. What we were talking about is whole breast radiation. There's something called APBI where we treat just the lumpectomy cavity. And that is also a short course of treatment, typically 5 to 10 fractions. And that has wider adoption in the United States. Yeah. Okay, any other questions? Thanks, everyone.
All the questions. Thank you.
Thank you.